I want to first give, oops, I don't know what that was. There I want to first give a shout out to OMAS, a group called MHRM in Texas, the National Council for, actually it's Mental Well-Being, and then the Substance Abuse Mental Health Services Administration. They are all important to this talk. I've pulled slides from a number of resources, and these are the main ones actually, because this is a pretty big topic. So we should have no problem finishing by 2:30 as usual. So tough room. Okay, nobody left. All right, so let me show you the video quickly here. This is a real quick overview. What is a CCBHC? And then I'll jump into it. I just thought it would be nice to start with something brief. Can you see the video?
I think that it really has given me a lot of hope for universities.
We can hear it, we can't see it.
Oh, I probably have to share it separately. Hang on, thank you. Let's see how this works here. I've got the video sound on, and here's the video. Hang on. Let me make sure my sound is still being shared. Yes, okay. All right, this should be better. Oh, that's right. You got to miss the advertisement anyway.
Too long, our nation's behavioral health system has been underfunded, leaving far too many without the care they need. The Certified Community Behavioral Health Clinic, or CCBHC model, is now transforming that. The CCBHC model gives states and clinics the resources and flexibility to address our nation's crisis and access to care. Participating clinics meet uniform standards that ensure everyone can receive the same high-quality, comprehensive care, regardless of their financial situation or where they live, and they receive sufficient funding to achieve this. As a result, CCBHCs are closing the gap in unmet need for care. They're making same-day access the norm, so no one waits for the care they need. They're ensuring expanded access to medication-assisted treatment, critical in treating opioid use disorder. CCBHCs deliver 24/7, 365 crisis support and care coordination with law enforcement to get people into treatment, not jail. Through crisis response, integration with physical health care, and care coordination with hospitals, CCBHCs are helping people stay healthier, preventing costly emergency medical visits and saving taxpayers millions of dollars. The National Council for Mental Well-Being is committed to making CCBHC status available to every clinic and bringing CCBHCs to every community by 2025. That means millions more people gain access to high-quality mental health and substance use treatment where and when they need it. Become part of this great work by visiting our CCBHC Success Center at thenationalcouncil.org/CCBHC to learn more.
All right. So that gives you a real quick overview, and it also explains why I shout out to the National Council for Mental Well-Being. They have become the experts right up there with SAMHSA, where the funding comes from. So I've actually been to the National Council meeting the last 2 years, and it is most of what they talk about. The other pieces they talk about are crisis, which is, of course, the other area that I do a lot of work in here in Summit County. So this is a nice graphic. It gives you a general sense of what they provide. The video covered a lot of this as well. And the bottom line here is this is going to become, and it's moving that way already, the best payment model in the whole country for mental health and substance use and ultimately integrated care. So that is really why it's important that you at least know that it's on its way. And I'll tell you more at the end when I talk about Ohio. But basically, this started back in 2014, and they are rapidly moving this forward at this point with a lot of money. So there's a lot of federal dollars behind this that, of course, flow to the states, and the states have to figure out how to use them. That's where Ohio is now, and we'll talk about that a bit. But it looks like a really good model, and it really is going to be the big change. And in fact, I think it's going to help fill in gaps that BH redesign in Ohio led to, and this should help to fill a lot of those gaps, including improve pay for clinicians working in CCBHCs or DCOs, which I'll explain in a few minutes here, that work with the CCBHCs around the providing of care. So 2014, as you see up top here, it started under an act called the Protecting Access to Medicare Act, interestingly, but somewhere in the discussions around Medicare for all and those types of things, obviously that hasn't gone forward, but this concept has gone forward, and it covers a lot of ground. If you think about if we could provide all 9 of these services everywhere in the country with rapid access for people, we'd be way ahead of where we are right now. So that's the concept, is how do we move this forward with these 9 components? So here's another version of this. It lays out, and by the way, you can't click on it here, but you can when I send you the slide set. You can click on some of these links. I left them in on purpose if you want to get more information about this. And they all either go to SAMHSA or they all go to the National Council for Mental Wellbeing, because they are truly the experts in this space, and will be for, I suspect, literally decades to come. So it's a big array of services. That other slide showed you the 9 main services. I won't review that again. But the concept here is that the CCBHC, that entity, probably in effect what had been a mental health center becomes a CCBHC, has to make the full array of services available to everybody that it serves. Now, obviously, to say that in that breath is not so easy, and to do that as one entity, you might as well have one giant CCBHC for all of Summit County and one for all of Stark County, right? But that makes it hard to give services to everybody because the counties are big, et cetera. So you get into the connection with other agencies to do that. It becomes the true safety net provider. When I was at North Coast, the state hospital, we tended to consider the state hospitals the ultimate safety net. But the reality is often mental health centers are the safety net. This adds a lot to those services. So you now have a much stronger safety net, both in terms of what they can provide and also in terms of the financing, to make sure that you can do this 24/7 and start from preliminary screening all the way to ultimate treatment plan. Who do they coordinate with? So currently most of the individual organizations that have been tapped as CCBHCs are already FQHCs. They're already federally qualified healthcare centers. Why is that? Well, they're already, obviously, those are all known entities to the federal government. They're already doing integrated care. They're already doing something around mental health, but not as robustly, I think, as the federal government was hoping. So by going to federally qualified healthcare centers and then letting them become a CCBHC, you get integrated care, which is right up the alley of this echo. So I mean, it's really important from an integrated care perspective here, including you'll see in rural health settings. They need to coordinate, though, with the whole system, just like the ADM boards do. We need our inpatient facilities. I certainly don't pretend that ADM board has any control over SUMA or Cleveland Clinic, but we need to collaborate with them for the care of the citizens of Summit County. And of course, those 2 entities serve a lot of counties. So we have to be able to do this in a good way. We also have to coordinate with the VA. So when a lot of things like our Suicide Prevention Coalition in our county, the VA is front and center. They were part of a movie screening we did last night. We rented out at the local theater here for a movie that's coming out. But we just did a preview last night. And, that gets the VA in there so we can also coordinate. And the CCBHCs are required to. Again, the VA is federal, of course, so obviously they're not going to leave them out in this model. And then, of course, all the inpatient and outpatient type clinics. What is a DCO? So these are the organizations that are a designated contract organization. They work with the CCBHC. And you can see here that there's a bunch of things that are starred that the DCA can provide, but the other things have to be provided by the CCBHC. So there's certain areas that they must show that they can do this, and they generally start with a planning grant, usually $1 million. In Summit County, we have one right now at Community Support Services, who are already an FQHC lookalike. So again, not surprising that they got the grant. We had one other big organization apply and not get it this time around. We're hoping they'll get it next time around, because it ultimately is going to be good for the citizens, good for the services that can be provided, and ultimately actually good for the clinician pay, which of course helps stability of the organizations. So you can see here they could work with the VA as a DCO, as opposed to CSS trying to do a whole array of veteran services. They can work with other organizations, Thrive and others, to get peer support services. They can work with NAMI. Actually, NAMI is already located in their building anyway, but work with them around family, other rehabilitation services, right? They don't necessarily have their own other buildings for the whole continuum. So you have to do that through this DCO arrangement. So that's very important. So here's a better graphic. Some people learn better from graphics. I've got a few interspersed that do a quick recap of that. You can see the main services. You can see the top ones have to be delivered by the CCBHC, and the bottom 5 can be designated through the designated collaborating organization. I think I said contracting. I mean collaborating. So, okay. Who else? Well, you can imagine to get all this done, they got to work with everybody. Schools, Summit County Children's Services in terms of CSS, but obviously the similar entities in all the other counties in Ohio and across the country, other social and human services, job and family services, right? There's a lot of issues here that would need to be coordinated with a lot of entities. SAMHSA does give a whole bunch of accompanying information, if you will, around the CCBHC grants that they're giving out. And so it covers a lot of places. They want to make sure that we're covering everybody, including Indian Health Services, suicide crisis hotlines. Now we have 988, so that's going to be a big component of this. So it's a heavy lift, and that's the reason they start with a year-long $1 million planning grant, because they may have to hire new people, and many of them do, to start to coordinate this. This really is a sea change in terms of the amount of an array of services. So CSS, for example, when they started to do this, reached out to me, suddenly asking questions about youth services. Well, they've never done youth services. That's not their area. So they need to now work collaboratively with ADM Board, maybe Child Guidance Family Solutions, Akron Children's, et cetera, as an example. They're going to have to work on that. They're supposed to do crisis services. Well, guess what? In Summit County, that's already designated through Portage Path for most of it. So they have to work together to figure out how are we going to make this happen for the entire system. The good news is that the DCOs do benefit, because if they provide the service, they also get the increased pay. So it goes through the CCBHC, but the DCO does actually benefit financially. That may be on the next slide. But the point is, so you've got the CCBHC is responsible. So they're the ones who are going to report back to the federal government and say, hey, or the state government, who then reports to the federal government. Here's what we're doing. So, but ultimately the DCO, what does that mean? That means the CCBHC, if they don't like the services from agency X, they could ultimately change it to agency Y. All right, it gives them some control over that, not instantly, of course, but over time. I've already mentioned which services can be provided by DCOs or not. So as a DCO, you're participating in this big effort. You're getting paid. So as I thought it's on this slide, it's much simpler. One payer. Right, you don't have to get a bunch of money from 900. Now you may still have other areas of business, but at least as far as this part goes, you get one payment. Right, you're working with one payment, much simpler. It gets rid of some of the fragmentation. So they don't state that anywhere in this exactly, but it does have that effect. It could decrease some of the payment fragmentation that we're all dealing with. The CCBHC will still feel it, but anybody working with them collaboratively may not feel that so much. That would be a win. I imagine many organizations would appreciate having what would be called like a bundled amount of money coming in. When we were in Arizona looking at their crisis system last December, they talked about having that array of services. They called it braided services. You know, like a braided rope. They literally, the local monies went up to the state, and then the state bundled everything together and brought it back down for crisis services. And in Ohio, they asked us, how did we do that? And I told them we were more like afraid not, pun intended. So, but true, right? So they at least laughed, but also felt bad for us. Their amount of their type of payment came out of a lawsuit from 1982, and it's taken them much of the 40 years to get to being the national model. So things will happen in Ohio as well. I think the CCBHCs working with DCOs are going to be a win ultimately, but probably a lot of growing pains. So here's sort of their simple version. You can see this is from the National Council for Mental Well-Being. The standard kind of definition of services, they're trying to raise the bar in all those areas I showed you. They want to go from evidence-based care to really guarantee the most effective care. So we've been doing evidence-based where we can. Obviously, not everything's evidence-based yet, and we've got a lot to learn in all of healthcare, not let alone mental health and substance use care. Quality reporting. So this is huge. Just like an ADM board, the quid pro quo for funding is data. Right, so this will give a lot of data at the national level from all these CCBHCs, which really should inform the legislature, the president, other governors, of course, as well, because it goes through the states to the feds. What do we need to do to further fill gaps? So I think there's a plan in place here that sounds better than when I first heard about it. It sounded kind of daunting and maybe confusing, but the reality is now, as I've learned more, I think it's actually being set up in actually a pretty good way. So it's got the prospective payment system so that they can ask for money in advance. Say, here's what we're planning. We need that money now, as opposed to waiting for the money later. Because lots of things get stopped when you say, well, I could do this if I just had some money up front. So ADM boards, like our ADM board, we do that sometimes. Agencies will say, if we could do X and have one-time dollars, we'll get this program going. PEGS Foundation also serves in that role a lot of times, and all of you are probably aware of them in the excellent work they do. So same idea, but this will be federal dollars, which means bigger dollars, generally coming down than an ADM board or even states can muster. So this is their graphic, the concept. It's a one-stop shop. You get all your needs met there, sliding fee scales or no fee, very much set up to accommodate anybody at all who comes in. Of course, that gets into culturally appropriate services. Everything has to be shown in the demonstration to the federal government that you are now ready to move on to in the planning grant to become a full demonstration of the CCBHC. That only works if the state is on board and has figured it out. So that'll be the end of this when I get to it. So it does have a lot of finances here. It gets into value-based purchasing, which is new to the substance use and mental health field. I know a little bit about it because we've been doing some of that here at ADM, where we basically pay for outcomes. So as a concrete version, CSS, I'll use them since we're talking about them as an example, they do supported employment. It's a phenomenal program because all of us do better when we're working. Yes, I crave my vacations as well, but when we're working, we do better. I need to do better like Dr. Robbins and do my work outside. But other than that, we got to do our work, and we're going to crave vacations, but we need people to work. We need them to have meaning and purpose. So the supported employment movement, which is evidence-based, is very valuable. And we now have made that a value-based purchase. So they literally send us pay stubs of patients who are working, and we give them money for that. So we literally review. I actually am the one who reviews it. So I review it because I sit on the steering committee with them. And then I say, yes, awesome. And we send them thousands of dollars. Right. That's not to the patient, to the organization. So the patients are getting paid through their work. So it's a really good model. It gets into a lot of other data structures. I'm sure ultimately our Health Information Exchange, which is OHIP, which is CliniSync. I happen to sit on their board. That'll be part of this with CliniSync. However, the electronic health records, many of the bigger hospitals now, and all of them in Summit County have Epic, but obviously they can all talk through CliniSync. Getting the crisis piece is huge. Another area that I like about it, and I'll show you a little bit more about that in a minute. So this is the most recent graphic since March that I can find. There are now more than 500 of these. So this is not new. It is growing. We're going to need a lot more than that for the country to make this model the model. But you'll see that. So you've got, even looking at the map, even some starting in Ohio here. The darker shades are where they're the most. So the original states that started doing this first, Texas, which is why I mentioned them in my acknowledgement slide. Texas has been a very early adopter of this. As have some other areas like New Jersey and so forth. So you'll see more and more on their website. If you go there, this list will show you where they are and how close they are to where you're at and what you're doing. Crisis. So I'm going to do some real quick slides on the overview here, and then we'll stop for questions and discussion. So crisis, not surprising. They want money in prevention. Our country is not good at prevention. We're awesome at tertiary care, which means after things are bad, we're probably the best in the world at that. Unfortunately, that does not make our healthcare system very good. We need prevention, like a lot of universal healthcare systems, to do this. And I don't think this is officially a push toward universal health care. But I think the goal is to try to create some bottom platform, which is a pretty good platform in this case, for all substance use and mental health care. So this is going to raise that bar for everybody, which is a good thing. So, and then of course we know about crisis and then post-crisis, right? We tend to treat, historically we've treated mental health exacerbation, mental illness exacerbation, or substance use exacerbation as a point in time. Oh, you got your care, you're done. We don't do that with a heart attack. There's a lot of post-crisis care after a heart attack. We need that model to also be true for substance use and mental illness. And that is what this is going to help promote. So we really understand that these are chronic diseases that deserve every bit as much energy, time, and money as things like heart disease and so forth. So expanding access, huge. These 500 sites have already shown excellent data about a very large increase in the number of people that they're able to serve. So even within a given CCBHC, they find with the money, with hiring more staff, et cetera, not surprising, they can serve more people. So that's the concept. So this is it's moving very fast. You get a sense of some other areas here, right, that gets covered. So here's this again. This is March of 23. Currently engaged versus others that are working. But again, it's like a big learning community as well through SAMHSA. So by learning this and Mental National Council, so you see this and that helps them grow. And oh, what are you doing over there? What are you doing? That's why I feel like we're going to need multiple in every state, and they will learn from each other. And then the ones that are CCBHCs will then collaborate with all the other agencies. I don't think we need to lose agencies. We need to collaborate better. And of course, if those agencies get a single payment for a lot of their services, that's going to be a win in the scheme of things. You can see here more about what's going on that improves access. Reducing healthcare disparities certainly in something we need to do more about than we have done historically. Gets into more training. Look at the increase, and that's a huge. This represents increases in terms of what they're doing. So 94% increase in cultural sensitivity. That's awesome, right? So we need that. This seems to do that. Even look at the jump in partnering with tribal communities. That was non-existent almost, other than the Indian Health Service. That was non-existent. This is already moving the needle to help a lot of people. Here's staffing. I only did one slide on staffing, but I'm going to talk about staffing with Ohio in a moment. But notice here how this works. Notice that if you're a grantee from the feds only, but your state is not yet certified, like Ohio right now, not certified. So let's say CSS moves on to being a grantee, but Ohio hasn't done their thing yet. They're going to get employee retention, but it's not going to be as good as if they have the state process. That's the bottom line of that picture. You'll also notice that because of the money, they're able to hire a lot more staff at these CCBHCs. That obviously improves care, and from my perspective, it should improve the fourth aim, or the quadruple aim, which is clinician experience, which we put almost no energy into in this country, and we need in my next life, that's going to be my whole focus. So I think that's what we need to do. And then, of course, who are they hiring? A big increase in peer support, recovery specialists, more data. Why? Because we need data. We need to figure out where the gaps are, and you can't do it without data. We're doing a lot of that at ADM, but we're still missing a lot of data, and as much as we keep adding to it. Anyway, even psychiatrists, because they can finally afford to pay psychiatrists. So that's a win all the way around. So here's Ohio. So I want just to spend a minute on Ohio. Where are we at? So these are the CCBHC goals in Ohio. This just launched recently in the last few months, actually. I think we had our first meeting in June. I am on the statewide committee for this, so I'm happy about that because I want to know more now that I've seen it twice at these national meetings, and I want to be able to work with our system here. So you'll see here they got 5 big goals. These are not different what I've just described to you in the other slides, but just so you've seen it, these are officially the ones that are being promulgated for Ohio. We had a meeting in June. They skipped July because, of course, they had to work out the budget, how that was going to flow, minor thing like the state budget. And then in August, we started meetings. So it's really just happened since last month. But we now have also multiple subcommittees, which I agreed to be on one of, and I think I'm now on 3 of them because they need input everywhere. But that's okay. That's more. I'll go to the ones I can. So, but if others see these, oh my gosh, I need to be on that, let me know, because they may still have a need for some people to be on some of these subcommittees as they are just literally starting. Some of them, like the workforce one, may require some of this other stuff like practice guidance before we can do this, or vice versa. They're not mutually exclusive. They all work together. So, but I think this is a great slide because it gives a good sense of the amount of work it's going to take for Ohio to figure this out. And you'll see here, of course, part of it is figuring out how much money are we going to give? I'll just use CSS for now. How much do we give them for what they're doing, which certainly will be a boost compared to what they've been able to bring in. But how much do we give them so they can do all the good things I just showed you on those last few slides, increasing staffing, increasing access, et cetera. That's a huge lift. So there's a lot of discussions on that. That'll be more fiscal type people and stuff. That's not one of my committees that I'm on, but that's the stuff that we need to figure out to make this work. And then again, just focusing for a second, and I'll stop here on the staffing piece. Well, what else are they going to do? Because we've got to do more than that. So there's a big intersection of what's going on with the wellness workforce and the CCBHC discussions and that particular committee that I do sit on, the workforce committee. What do we do? How do we help from, again, it's almost like starting with prevention. How do we get people interested in these professions? So they, like all of you and I did, and you go to all that education, you come out and do the work. So how do you do that? How do you marry that to recruitment? So that people realize, oh, wait a minute, there's a job right here. I don't even have to move, because that's true in almost every community right now. And yet there are gaps in getting people hired. How do you retain those people? Right now, again, some of this may be money. Everyone's, oh, it's not the money. Well, sometimes it is the money, if we're honest. And people do jump, especially when they're at the lower paid types of clinicians. They're going to jump for a couple of $1 an hour raise. Why? Well, because that's $4,000. That's a lot of money jump. So they're going to jump for that. We need to figure out how to not have that happen and get stability, which ultimately is more stability for the clinicians and, of course, for the patients who don't want to see yet a new counselor again after 4 months, because that happens all the time as well. So there's a lot of good stuff here around this. So just so you're aware, this is being worked on. You'll see here, of course, Department of Medicaid very much on board. This is really a Medicaid, OMAS, Mental Health and Addiction Services joint venture. This is because it's got to be the money and it's got to be the service. So that also is being done, I think, in the right way. This is a slide from the workforce group that I just started sitting on, and just started the committee on what we're trying to work on, and here we are. So we've got a lot of data. They've done a lot of scans on what the data is in terms of what the need is across using Ohio Council data, which covers, I think, 450 agencies across the state. They've got some data from the Ohio Hospital Association to get the hospital data. Strategies have been worked out. There's a big roadmap on their website if you want to see that. And then we're looking at how do we implement all this to move this obviously to the, once it really works, then we'll keep evaluating. It'll become a plan, do, study, act type of cycle. So finally, just in case you're looking for it after this whirlwind talk on what is otherwise about a 10-hour talk, National Council for Mental Wellbeing. There's their website. Again, you'll be able to click on that when you've got the actual slide set. And SAMHSA are the big ones. This is just a quick graphic that shows you what's going on, but this was down and dirty compared to what's really going on. There's a lot to this, because it will be the way to pay for substance use and mental health services. This is the model. I don't think it's going away. It's a bipartisan buy-in. It's not something that's going to change because we change presidents or governors or things like that. So, all right. And that's, as usual, my contact information, and I will take questions.